So let me start off by asking a few questions. Do you think this optic disc is normal? We'll just self-evaluate, 10 seconds per slide. What about this? Do you think this optic disc is normal? Is this optic head normal? Is this a normal optic disc? What about this? Is this a normal optic disc? Are these optic discs normal, or do they make you think in terms of glaucoma? Is this optic disc normal? Is this a normal optic disc? Are these optic discs glaucomatous? Is this a glaucomatous optic disc? Are these optic discs glaucomatous? Is this optic disc glaucomatous? So when we say glaucomatous, we mean, does it make you think in terms of a high suspicion for glaucoma? Is this a glaucomatous optic disc? Is this going to make you think in terms of glaucoma? Is this optic disc glaucomatous? Would this make you think in terms of glaucoma? And what would be your preferred instrument of choice to look at the optic disc? So if you look at the current definition for glaucoma from the American Academy of Ophthalmology, it talks about a very specific pattern of changes to the optic disc and the visual field changes. Now this was the old definition, where they said you need not have a high intraocular pressure to diagnose glaucoma. It was typically glaucomatous changes to the disc and visual field changes. But then remember that visual field changes will happen when 40% of the retinal ganglion cell complex begins to get damaged, and disc and nerve fiber layer changes happen much before. So the definition of glaucoma has undergone a change, and they talk about glaucoma being a typical optic neuropathy with a specific pattern of changes to the optic disc and retinal nerve fiber layer, irrespective of the intraocular pressure level which is achieved. So in the next couple of minutes, we're just going to look at changes which can happen in the disc and in the vicinity of the disc, so that we can answer some basic questions. Are these optic discs normal? Is this a glaucomatous optic disc? Can we differentiate non-glaucomatous from glaucomatous abnormalities? The first thing we look at is the size of the optic disc. Now, small size optic discs can be seen with drusen's of the optic disc, an anti-ischemic optic neuropathy, various conditions which can mimic a papilledema. Large size optic disc will be seen in high myopes, and whenever you have some congenital remnants of the tissue. Typically, Caucasian optic discs are the smallest in size, Afro-Asians are the largest, and we Indians come somewhere in between. So there's a correlation of the disc size with refractive error, but typically when you have a myopic disc, it's very difficult to differentiate it from a glaucomatous disc, simply because the disc is large in size, has a large cup disc ratio, there's an associated peripapillary atrophy, nerve fiber layer changes, difficult to appreciate, neural rim changes, difficult to appreciate. So, a myopic disc can often be thought to be a glaucomatous disc till you prove it is not so. How do we identify the size of the optic disc? And the best way of doing this is to look for the inner border of Elschnig's ring. At the first glance, this appears to be the optic disc margin, but that's not right. The inner border of Elschnig's ring is marked by the blue line here, and that's what we need to pick up. Typically, use the vertical rule at the slit lamp to measure the size of the optic disc. The important thing to remember that because of this halo, the optic disc will always be smaller in size than what it appears to be. So how do we measure the optic disc? At the slit lamp, use any of the stereoscopic lenses. The vertical beam can be read off in millimeters. Important to keep in mind that there's a magnification factor involved with all these lenses. Is it practically significant? Perhaps not, but you need to be aware about it. At the same time, the same powered lens from different manufacturers could have a different magnification factor. So that's something you need to keep in mind if you're actually going to apply planimetry to these things. The direct ophthalmoscope is perhaps not an ideal instrument to look at changes for the optic disc. It is good if you want to assess the size of the optic disc. It is good if you want to follow individual vessels to assess vascular phenomena, but not good for a three-dimensional view of the optic disc. In addition to size, the second thing you look at is the shape of the optic disc. Typically, the optic disc is vertically oval. So if you see a disc which is horizontally oval, particularly say in a child, you need to rule out a corneal astigmatism. Make sure you've done your refraction under dilatation for that child. So size is important, shape is important. It's very important to correlate the size of the optic disc with the cup size and also the neural rim. Remember, the outer border of H-Nix ring, inner border of H-Nix ring is what we use to identify the size of the optic disc. We can use the vertical rule of the slit lamp to measure the size of the cup, typically marked by the junction of the circumlinear vessel that is usually present at the junction of the cup rim margin. Another way of identifying the cup rim margin is to look at the vascular changes. So when the blood vessels enter into the optic nerve, the first changes as it climbs onto the optic nerve, and then the second changes as it clambers onto the neural retinal rim. So in an example like this, the first impression would be that the cup is ending here because of the change in the vessel. But if you see well, this is the second kink as the vessel is well focused as it clambers onto the neural rim. So that's your margin of the optic disc. And for this reason, if I say that the optic disc is usually smaller in size, the cup is usually larger in size than what we think it is, because it's the second kink in the vessel as it just clambers onto the neural rim from the cup walls. So remember again, correlate the size of the optic disc with the size of the neural rim, because small size optic discs will have small neural rims and large size optic discs will have large neural rims. So when you see a patient like this, remember that small discs should ideally have no cups, just as large size optic discs will have large cups. So when this patient presents to us with an intraocular pressure of 35, you see this small size optic disc, don't take it to be normal. And because the diagnosis again would not be ocular hypertension, it would be primary open angle glaucoma, because small discs should have no cups. And for the same reason, don't treat this patient as an open angle glaucoma simply because it's large in size and has a large cup disc ratio. Bearing of the circumlinear vessels, a nasal shift of the vessels are soft signs as far as diagnosis of glaucoma is concerned. Whenever in doubt, remember size of the disc, look at the rim and the shape of the optic disc. How many people think these are normal optic discs? Just raise your hand. So I think it's either the post-lunch thing, nobody's raised. So you all think this is the glaucomatous optic disc? One. Okay, so what about this? See, large cup disc ratio should actually, how many people think these are normal optic discs? Okay, so I think it's a small number. This is just to emphasize these were actually normal discs, large disc size and therefore a large cup disc ratio. A large cup disc ratio is not synonymous with a glaucomatous change. It's important to look at the thickness of the neural rim. So typically if you see, the optic disc is vertically oval and the cup is horizontally oval. So as glaucoma progresses, the superior temporal and the inferior temporal rim tends to be lost first. And that's why we are focused on the neural rim. The work on the neural rim established by the fact called the ISNT rule, the inferior rim is normally wider than the superior rim and the nasal rim is wider than the temporal rim. It comes from work done in Caucasian eyes by Werner in Philadelphia, and I showed you this optic disc earlier. So when you see this average size optic disc, you find that the inferior rim is the large cup disc ratio, but the inferior rim tends to be wider than the superior rim. And the nasal rim tends to be wider than the temporal rim. So a large cup disc ratio does not mean glaucoma, right? But the moment you look at the optic disc on the other side, Same size optic discs, the inferior rim is narrower than the superior rim. Are we together on this? And there is an obvious nerve fiber layer defect, so obvious that even with white light you can pick it up. And if you see very carefully, there's a nerve fiber layer defect happening here also. But remember, it's always both the discs that you look at. And this disc would raise your suspicion for a glaucoma to a very high level. You can use the red free light at the slit lamp to pick up this nerve fiber layer defect. But remember, the ISNT rule is applicable only to optic discs which are vertically oval and not those optic discs which are horizontally oval. The next thing we look at is the nerve fiber layer for changes. Now, typically, these are the opaque striations that you see, and they follow the distribution of the ISNT rule. Two kinds of nerve fiber layer defects. One is the spindle-shaped defects, as you see here, and there's nothing pathological about them. It's these wedge-shaped defects. This arrow is a little off. This is the wedge-shaped defect that you see here. Classically, the apex of the wedge will point towards the neuroretinal rim area. And it's indicative of an ongoing ischemic damage to the optic disc. I showed you this picture. How many people feel that this is not a normal optic disc? Okay, so that's a very small number. Small size optic disc should have no cups. When I first saw this patient, I assumed it to be a normal optic disc. We got the fields done because the pressures were raised, and we had this little inferior nasal depression on the visual fields, which I got the fields repeated over the next couple of days because I just felt it just wasn't right, and we had seen the patient under dilatation and not very convinced. And then we picked up on one of the subsequent examinations on the dilatation this nerve fiber layer defect, which was actually correlating with the visual field change that we had seen earlier. So again, to emphasize, nerve fiber layer changes can be seen in conditions other than glaucoma. For example, when you have retinal scarring or druseness of the optic disc. Very often, nerve fiber layer changes will not be picked up because of cataract, because of inadequate illumination from the slit lamp. But I think an effort needs to be made every time. I showed you this picture earlier. Average size disc, inferior rim narrower than the superior rim, and there's a wedge-shaped nerve fiber layer defect that you can see here. You can pick it up with the cobalt blue light or the red free light at the slit lamp. So it's important to look for nerve fiber layer defects. Disc hemorrhages, also called as Drans hemorrhages, are very important because in a normal population, only about 0.4% would have disc hemorrhages. But in a glaucomatous population, 4 to 7% would have disc hemorrhages. Very, very important to pick up these vessels, these hemorrhages, splinter-shaped, and typically you'll miss them. You got to ask yourself, did I look for a discontinuous blood vessel? Because that's how you're going to pick up a disc hemorrhage. Typically, on the disc or within one disc diameter of the optic disc, in the absence of other conditions which can produce, for example, like diabetes, hypertension, venous occlusions. And just to emphasize, a clinical examination in the OAT study was able to identify disc hemorrhages only in 16% of patients. But when they went on to disc photograph, the identification went up to as high as 85%. So remember that these disc hemorrhages are indicative of progression, and you need to reset the target pressure for your patients. It can happen in other conditions, as I said earlier, and it's important to make sure that the patient is not on blood thinners also. Typically, the disc hemorrhage will get absorbed over a period of time and will be replaced by this nerve fiber layer defect. So it's important that you look for a discontinuous blood vessel. Now, this is a little controversial, but it's important to know that changes in the vicinity of the disc would include peripapillary atrophy. There's an alpha zone corresponding to the irregular pigmentation of the retinal pigment epithelium, and then you have the beta zone, which is the hypopigmented area producing an absolute scotoma. Basically, based on an observation that patients with advanced glaucomas tend to have large peripapillary areas. So remember, very often you can see the optic disc and draw your diagram. It works out quite well. Remember to look at the size of the disc, the shape, correlate the size with the cup and the rim size, look for the ISNT rule, look for nerve fiber layer changes, and the disc hemorrhages. So run through the checklist. You agree that this is a normal optic disc? Okay. Same thing for this. You're going to be inclined to think of this being a normal optic disc. Same thing here. Run through the checklist in your mind. It will take time initially, but soon you'll pick up speed when you come to see it. So I showed you this picture. Inferior rim narrower, nerve fiber layer defect in an average size optic disc. So this would be highly probable from the point of view of glaucoma. Take a look at this, one of our patients. Baseline examination in 2007, and then in 2008, there was a narrowing of the superior temporal neural rim here. Again, patient photographed in 2007, January, June, December, and then 2008, you find that there is a gradual narrowing of the superior temporal rim, which is happening there. All signs of progression. Take a look at this. Nerve fiber layer, this is the baseline examination, and you find that there's a thinning which is happening in the superior quadrant here. This is typically inferior rim narrower, and you can see the obvious nerve fiber layer defect here. But remember to run through the checklist whenever you see the patient. That's the thickness of the other side. The important thing to remember that whenever there is an asymmetry in the thickness of the retinal nerve fiber layer of 25%, it will produce a relative afferent pupillary defect. And eyes which have an RAPD are likely to progress faster than the other eye. Changes can happen in the nerve fiber layer defect. Now you see this patient with a nerve fiber layer defect here, but this area didn't have a defect. Over a period of time, there's a new area of nerve fiber layer defect which has begun to manifest. So again, progression, and you need to reset the target intraocular pressure for this patient. Another form of change in a nerve fiber layer defect, you have this defect which you see here. This defect is already present here, but over a period of time, look at this marker here, the kink in the vessel here, and the nerve fiber layer damage has now progressed to come up to this kink. So again, expansion of the retinal nerve fiber layer, wedge-shaped atrophy in a patient with a pre-existing nerve fiber layer change. So remember, the visual fields are going to pick up the functional loss. And that's one of the ways of detecting structural damage to the optic disc. So there's always a correlation. If the inferior rim is damaged, it will produce a superior hemispherical defect. So is this optic disc normal? If you apply all the things that we have done, the typical thing is the nerve fiber layer defect that you see here, which is actually happening because of this patch of choroiditis. So be very important. It's a clinical examination needs to be done incomplete before you actually make a diagnosis by looking at one part. We discussed this earlier. This is an average size disc with a large cup disc ratio. Look at the other side, and the asymmetry of the inferior rim and the nerve fiber layer damage will make you think in terms of glaucoma. Discontinuous blood vessel, typical for you to run through the checklist and think in terms of glaucoma. So this is a patient where the disc hemorrhages got absorbed and replaced by a nerve fiber layer change. One of our patients had a pre-existing nerve fiber layer change, not photographed well. The person taking the photograph sat up when a year later the disc hemorrhage got added to this. So you see this in 2007, and you find a disc hemorrhage happening on a nerve fiber layer change. Disc hemorrhage in 2004, the picture in 2004, and you find the disc hemorrhage happening in 2005. If you look at the grayscale here, you find just a single spot, a depressed point. Over a period of time, it manifests, but I think if you look at the fields by themselves, you would not consider them very significant at this stage, and you would need to correlate it with the clinical examination where the disc hemorrhage is now getting replaced by a nerve fiber layer defect inferiorly. Now, disc hemorrhages over a period of time, same patient. And they are often associated with alterations in the nerve fiber layer, loss of neural rim and volume, and visual field deterioration. So it's important to remember that sometimes peripapillary atrophy can antedate the presence of the disc hemorrhage. So as I showed you earlier, these are glaucomatous discs. In my examination, I missed the nerve fiber layer defect, which was actually producing inferior nasal depression on the visual fields. This is again a glaucomatous optic disc. Run through the checklist in your mind, and you'll find that the nerve fiber layer defect and the thinning of the rim is very, very typical. See this here. you can draw a good clinical diagram and use it to assess progression over a period of time. Mark out the contours or the kinks in the vessel, the nerve fiber layer changes, and the hemorrhages with a colored pencil, and that should help. Now, it's important to remember that cupping is a three-dimensional phenomena and best seen and should not be mistaken for pallor of the optic disc. Pallor is more in favor of a non-glaucomatous lesion, a neurological lesion, while loss of neuroretinal rim is more specific for glaucoma. Is this optic disc glaucomatous? Run through the checklist. Not sure, get the visual fields done, and they'll help you take a decision as to whether to think in terms of glaucoma or not. Now, with all this background, I still often have discs which worry me and discs I have trouble in interpreting. For example, discs like this, similar size optic discs, asymmetric cupping, pressure is normal, angles open, and visual fields are normal. Asymmetric cupping in optic discs of equivalent size, or when I see loss of neural rim along the vertical axis in optic discs which are actually horizontally oval. When the inferior rim is thinner and there is no obvious tilt to the optic disc. When bearing of the circumlinear vessel is an isolated sign in the absence of any other feature for glaucoma. Disc hemorrhage as an isolated presentation in a patient who has come for a routine eye examination. Small size optic discs and large size optic discs. Patients who present with a large area of peripapillary atrophy. Drusen's of the optic disc and tilted discs. Whenever we see an abnormal shape to the optic disc, that's again where I have difficulty, as you see here in congenital anomalies. So the take-home message is simply this. Whenever you see an optic disc, where your suspicion as an individual, as an examiner, is more to think in terms of glaucoma, the next test you get done is the visual fields and no fancy imaging test. I'll just close by showing you one of these patients, average size disc as you see here. The visual fields produced on the octopus and the Humphrey, they produce the typical inferior depression as you see here. We got the OCT, the GDX, some of these images done, all of them showed a superior thinning of the neural rim. Clinical examination picked up a superior thinning of the nerve fiber layer. There was a double sign here because of the pigmentation at the lamina cribrosa. You can see this here. There's an RNFL defect here, which was producing this consistent field effect. And you can see this nerve fibular defect also has a prominence of the superior vascular arcade as compared to the inferior arcade. And this is what was producing the change on the imaging devices. The question is, should we treat this patient or not? Pressure is not important because currently they say don't diagnose your glaucoma based on pressures alone. You have reproducible structural and functional changes. So this was a patient who actually had what we'll call as a hypoplasia of the optic nerve. Typically happens in the superior quadrant, can happen inferiorly also. Typically these changes will be non-progressive in nature, and you will have no other risk factor to think in terms of glaucoma. Seen in mothers who are pregnant, alcoholism, and have drug dependence, and have thyroid disorders. The diagnostic criteria here would be an intracranial optic, where the intracranial part of the optic nerve and other features are suggestive of septic optic dysplasia. So I'm going to stop here, and I'm going to thank you very much. But remember that whenever you have a structural change to the optic disc or you suspect structural damage, the next step is the visual fields. That is more important than getting any of these imaging device tests done. Thank you.